And it's a pleasure from the LGS team to welcome Professor Ananthakrishnan. Actually, he's my teacher, mentor, and mentor to a few hundred surgeons across the world. And it's a privilege, sir, to have you here today.
Thank you so much, Pata. Good evening, Chandra Mohan. Good evening, everyone. Greetings to all of you, and it's a great pleasure to be here. Last week, we had a case discussion on corrosive injury. Unfortunately, because of some problems with my modem, I could not participate. So I thought I'll share some few things I have learned about corrosives over the last 40 years, managing a lot of patients over the years, because there are many areas of controversies and more than one opinion about many of the issues. And it's worthwhile knowing what's the hard evidence so that when we make a decision, we can choose the correct option, although there will be areas where there are still over the last 40 years, it's everybody's choice. I'll try to make it quick so that we have a lot of time for discussion at the end, and I'll try to answer some of your doubts if I can. I'll be focusing only on areas where even today, a lot of things happen which should not be happening, in spite of best efforts to educate the young surgeons. Last week's case treated in the year 2019, but I will remember, the first thing the hospital did was to give a stomach wash and try to neutralize the corrosive. This is a very, very dangerous practice for several reasons. One is that the tube passed can by itself cause trauma. If you give emetics and produce violent vomitings, it can cause injury to the esophagus and to the oropharynx, which had escaped previously. And lastly, you do not really know what fluid should be used for neutralization, because you see a simple thing which I said last week, that patient had taken Harpic. Now Harpic floor cleaner is strong alkali, whereas Harpic toilet cleaner is 10% hydrochloric acid. And whatever it is, when you try to neutralize, you produce a lot of heat, and the thermal damage is added to the corrosive damage, and it will make it much worse. And I think we should stop this practice and educate everybody that stomach wash and neutralization are no longer permissible. Timing of endoscopy is a matter of controversy, and I'll dwell on that for a little bit. The role of investigation, the role of steroids, a lot of people still use steroids, and we'll see the evidence in favor or against steroids, and the timing and role of surgery when it is indicated vis-a-vis dilatation. These are all issues which we'll try to cover in the next few minutes about acute injuries. Now, every book in endoscopy or on surgery will tell you that you must do endoscopy as early as possible. Now, 48 to 72 hours is the time mentioned in most of the books. But when you have seen a few hundred cases, as I've unfortunately seen, you will realize that when you do it very, very early, and this early endoscopy has been driven by the insurance people in the United States, because you have to prove that it is minor injury and get them out of the hospital as soon as possible. Early endoscopy runs the risk of everything is erythematous, everything is edematous, and you overestimate the extent of damage, and there has not been enough time for the damage to depth to occur, and therefore you underestimate the depth. And very often you find that you have to repeat endoscopy anyway after a few days in order to get a correct picture about the actual extent of damage. I personally never do early endoscopy unless the amount is so small and they want to go home. There is no evidence of any oropharyngeal injury, There's no evidence of laryngeal injury, and we do it as early as recommended in order to make sure that there is no damage, and then tell the patient that they can go home and come periodically for follow-up at least once more to make sure that we have not missed anything, or come earlier if they have any symptoms. I do it late, much against recommendation, 7 to 10 days after injury, because it gives you a better picture of the depth and what you have to do. You've now had a perforation due to endoscopy. If you do not use undue insufflation, or if you don't use insufflation at all, and you keep a 360 view of the lumen while passing the scope, and completely avoid retroflexion in the stomach so that you don't turn it back to look at the cardia. That endoscopy 7 to 10 days later, when you see the extent of gastric outlet damage, it gives you an indicator that that patient will require feeding the duodenostomy early, because you're not going to be able to manage with oral nutrition, because it's going to take a long time to heal and a long time to assess whether the stomach requires resection or not. I know of some cases who had endoscopic ultrasound and been referred after that. A lot of articles have appeared in the early part of the century and disappeared after that, but largely because people have found it useless. It's safe, no doubt it's safe. They diagnose depth by seeing circumferential thickening and edema and lack of differentiation between the mucosa and submucosa. But most studies, some of which I have listed here with a large amount of patients, show that they are unreliable for depth, and they did not increase the accuracy, that's the most important, of prediction of either early or late complications like perforation or stricture. Therefore, it is an added procedure which has very little value. We have to have a very low threshold for doing CT wherever indicated, where sufficient corrosive has been taken or very strong corrosives have been taken. It's an excellent investigation, and wasting time with plain X-rays, we can directly proceed to CT with intravenous contrast. And I'll show you some pictures of the free perforation here. A free perforation plus gas in the wall of the stomach, which shows that it's very likely to perforate anyway, and an indicator for early laparotomy. And here also you see gas bubbles in the stomach plus free peritoneal air, and this is a large pneumoperitoneum. So the threshold for CT should be very, very low, and I think it is probably much more useful than endoscopy in order to assess the extent of damage and the risk of complications which will mandate immediate surgery. Now the next thing is the controversy about steroids. There are a lot of people who still use steroids, and over the years it has been published on and off, and I'll show you major results of some of these which have a sufficient number of cases in order to be able to draw conclusions which are valid. This is one of the first articles which is quoted in every place, published in the New England Journal of Medicine, a total of 60 patients with corrosives. Steroids were given to 31, prednisolone at a low dose by the intravenous route, followed by oral route for further 3 weeks and control. And you see the follow-up was by barium swallow, no difference in the stricture rate between those who received steroids and those who did not receive steroids. Another study which followed soon afterwards, larger number of patients with 361 patients, 72 of whom had grade 1 burns and 253 had grade 2. And steroids were given to 90, no steroids in 41%, and the stricture rate they showed was significant. So it again started a controversy. Anderson had shown it is useless, and Howell showed that it may be useful in preventing stricture formation, and the usage went on. Then a further study came at the turn of this century, and 60 excluded, and we do not know why those were excluded. 50 were with steroids, 51 without, and same this time methylprednisolone at a low dose of 3 milligram per kilogram per day for 6 weeks, and no difference in stricture rate when reviewed at 6 weeks with barium swallow. So again, it tilted it in favor of no steroids. This paper is from Turkey, and their conclusions were that whenever you have third degree, they'll get stricture, and then steroids are neither useful in acid burns nor in alkali burns, and it's a waste of time. And in fact, he goes on to say that it may add to the morbidity by increasing risk of sepsis in some of these patients, but not in all. This is the latest paper, but you know it is now 6 years old, and very few publications after that, which makes you wonder if it was so good, why other people have not used it and published. This is published in Pediatric Corrosive Injuries, 83 patients with grade 2B injury, 42 with very high dose of methylprednisolone. Mind you, the last we saw was 3 milligram, here 1 gram per 1.73 square meters with ranitidine for 3 days intravenous with ranitidine and antibiotics and total parenteral nutrition, and 41 without. And they showed that endoscopy stricture rate reduced from 30 to 10.8% and barium stricture rate from 45 to 14.3. So high dose methylprednisolone may have a role in the management of corrosive injuries when given over a short period and does not usually cause harm. There are 2 other articles after this, one of which says it is useful and one of which says it is not useful. Now it's left to the users to decide whether they would like to try it in some of their patients or not. But over the years, the evidence has never been very, very strong. One other topical agent has been used, and it has been used some 12 years ago, and again an article has been published 5 years ago, that after dilatation you inject topical mitomycin C using an endoscopic sclerotherapy needle into the area of stricture. And the control group had triamcinolone, and the test group had a very small number of 16 patients with topical mitomycin, and they found the outcome they measured was the median number of dilatations required after this injection of mitomycin C, which was given only once after the first dilatation. The median number significantly dropped to 4 and 4.5, and with triamcinolone it was quite high at 11. No follow-up papers, which makes you feel that the data was not reproducible. So again, the topic is open, and it is anybody's choice whether to follow it or not. But the fact that not many people have published good results means that in other people's hand, it was not able to give the same results. Whenever you're managing a patient with corrosive injury, we have to have a very, very low threshold for diagnosing respiratory injury, because if you send some of these patients home with respiratory injury, they can come back very seriously, or they may die in the house of asphyxia. All of them will have stridor or hoarseness. You have to assess by laryngoscopy. They have been treated with steroids, but you should never intubate through the burnt larynx. And if the airway is compromised, it is much better to do a tracheostomy than to put an endotracheal tube through that, because that only spreads the stricture and probably makes it much worse. But the message is that if you have stridor, you should not send that patient home, and they should be retained in the hospital unless and until you are sure that the laryngeal edema or the injury is moved one way or the other, so that if necessary, you can do a tracheostomy or if the edema clears, then you can discharge. A lot of talk about endoscopic stents after dilatation, both all of them removable and recently biodegradable. But the problem is most of these patients, and one thing that I have noticed, and probably others who have seen a lot of patients would have noticed, that when it is injected with accidentally by children or by adults, because it's not known that what they're drinking is corrosive, the oropharyngeal damage is less. But if it is ingested with suicidal intent because they're hesitant about swallowing, they take small steps till they work up courage to take a little more, oropharyngeal damage is much more, and I've consistently seen this in all my patients. And the proximal end of this affected area is almost at the laryngopharynx level or the cricopharyngeal or pharyngoesophageal level. And that's not a good site for putting a stent, because the proximal end of the stent would be sticking into the back of the throat, and it's totally unacceptable to the patient because it produces a very bad foreign body sensation. So stents are useful, if at all, only for injuries which are a little more distant from the pharyngoesophageal junction, so that the proximal end of the stent remains below the pharyngoesophageal junction. And what is the literature about stents in refractory benign strictures? This paper is recent, and their conclusion was stent therapy was not effective in increasing the dysphagia-free period compared to dilatation or reducing the number of frequency of dilatation. So when you find a number of people who are strong advocates of stents, and you have to counsel the patient, you have to give them this information, that it may not really be very useful in many patients. Degradable stents, the experience is very, very low, and only few series have been published. And polygalactic acid is used, the same material that is used for making vicryl sutures. And it's automatically disappears or gets absorbed after some time by hydrolysis. And they used it in 2 patients, and they said that it may provide some relief. But there are no really large series with biodegradable stents for us to advocate that as a management choice in these patients. It's another thing that I have found, that the incidence of tracheoesophageal fistula is sometimes overdiagnosed. And I am just showing a sciagram of one of our own patients. When you have a stricture very, very high up in the pharynx, as you see here at this level, what happens is there is no fistula, but it overflows into the trachea. And if you take a delayed film and do not show this, you will see this, and you will say there is a tracheoesophageal fistula when it does not exist. So barium or any contrast should be done under fluoroscopy, so that you follow it right from the mouth in order to make sure whether the contrast you find in the trachea is from the overflow contrast or it is through a fistula. Because then tracheoesophageal fistula is one of those conditions which requires a little different management, and you have to be sure whether it exists or not before you start treatment. This is a true tracheoesophageal fistula at the level of the carina. There is no overflow into at the level of the pharynx as seen on fluoroscopy, and you see a lot of overflow at the level of the carina, which has filled up the distal esophagus, and then it has come back a little bit into the proximal, but not significant. So you have to be able to differentiate these corrosive tracheoesophageal fistulae from overflow, which looks like a tracheoesophageal fistula. And whatever images I am showing today are those that we have from our own series and not from published data. So those of you who see a lot will also have seen some of these things. Another thing which a stent does, And this is the danger of the stent. This is a patient who had a stent outside for mid-esophageal stricture, and the stent had completely corroded the tracheoesophageal wall and entered the lumen of the airway. And this patient came to us with hematemesis, respiratory compromise, but relatively able to swallow well. But whenever he swallowed, he'll have violent fits of coughing because of the fistula which the stent had produced. You can see it here at the level of the carina, which has entered the one of the bronchi, and here lower down it lies in the esophagus. There it has gone into the bronchus, lower down it enters the esophagus. And if you do a bronchoscopy in this patient, and we have done, we see this ulcerating into the bronchus. So this is another danger of these stents. And stents should be used with care and should not be used where there is any suspicion of damage to the intervening wall between the trachea and the larynx. And the patient should be closely followed up. And anyway, I personally feel the self-expanding stents are harmful and probably not indicated in these patients. Although many of the medical gastroenterologists, some of them my close friends, would disagree with this. This is an article about removable esophageal stents, and this summarizes the view. Although placement is possible and feasible, it's frequently complicated by stent migration and chest pain, and some of which is unacceptable. And when you remove it, the strictures reform. One thing I've learned over the years is there is no period at which we can say the fibrotic tendency has ended and there will be no progression. I've seen fibrosis progressing for years together, and what you think is an adequate lumen becoming gradually compromised. Although most books will say that 6 months to 1 year is probably the maximum extent. But that's not really true. One more controversy in this area is the sphere of carcinoma. That corrosives can produce carcinoma, alkalis produce more carcinoma than acids, and therefore you must remove the esophagus wherever possible. Because you leave it behind, you risk the patient having a malignancy. But if you accept that argument, no patient with corrosive should ever be treated by dilatation. Because even today, the vast majority of patients with corrosives are treated by dilatation, and retaining the esophagus is acceptable in them. But only those who come for surgery, we have to remove the esophagus in order to reduce the risk of carcinoma, which seems to be a very irrational conclusion. I have reviewed this literature extensively. Almost all papers published. One paper says it constitutes roughly 7% of esophageal carcinoma. The denominator is not known. How many thousands they studied. The mean interval is 40 years plus, which would be well beyond the lifespan of most of these patients. And it is very strongly shown that there is no proven consistent correlation with either the substance ingested, acid or alkali, the depth, whether it is deep or superficial, or with the length. And with that's about esophagus, and with gastric corrosive injury, there's absolutely no correlation. So the risk of carcinoma should no longer be an indication for us to do an esophagectomy, because long ago it has been written, and it remains probably true to a large extent. The risk of removing an esophagus with a lot of periesophageal fibrosis and separating it from other mediastinal structures is possibly more than the risk of carcinoma in leaving it behind. The significance of the statement is that once you do not remove the esophagus, the posterior mediastinal route is close to you for conduit, and therefore you have only a choice between the substernal route and the subcutaneous route. There is another complication which is touted as a cause for removing the esophagus, which is mucocele. That is, you have a segment of esophagus closed at both ends, which continues to secrete mucus, and you have a large mediastinal cyst causing compression. The reported cases are very, very few, hardly any in fact, because the mucosa is so badly destroyed that it no longer secretes mucus. Not enough collects for the esophagus to dilate. It's so fibrous that it cannot dilate anyway, like Mirizi's law in obstructive jaundice. And if you do a side-to-side esophageal anastomosis in the neck, whatever collects can come out through that anastomosis. So that again is not a reason for removing the esophagus. The esophagus only reason for removing it is if it's so badly damaged that it's already perforated, or there is a very high risk of perforation. These are the papers from various times, and I've already told you the summary of some of those. The correlation is not strong enough to warrant esophagectomy, and that would completely destroy the indication for any patient being treated with dilatation. Now, the next thing which I am obsessed about is that the cervical esophagus is an extraordinarily important segment when you are considering a conduit, and we should go all out in order to retain that, so that we do the anastomosis below the level of the pharyngoesophageal junction. Anybody who has done these conduits in large numbers will know that the quality of life is very, very poor after pharyngocolic bypass or pharyngogastric bypass. Even in patients where the larynx is blocked and there is no aspiration, but they find it extraordinarily difficult to swallow because the deglutition mechanism is so compromised that they are not able to generate force in order to push a bolus through that anastomosis. And luckily for us, in most patients we find that there is a pharyngoesophageal junction stenosis. There is a segment of esophagus below that which may be 6 to 7 centimeters or up to 10 centimeters, relatively normal and preserved. And then you have a dense stricture from the mid-thoracic region or the region of the aortic arch or the carina. And if you can preserve that or reconstruct that segment and get your conduit anastomose there, and that segment gets connected well to the oropharynx, the results will be much better than if you do an anastomosis to the pharynx itself. The risk of aspiration is reduced. The length of conduit required, which may be only a few centimeters, but very often that is the critical segment at the end of the mobilization, just when you are about to do the anastomosis, find a segment you're not very happy with, and that is the most proximal end. And if you remove that, then it does not reach anymore. And if you anastomose it anyway, you'll end up with an ischemic stricture which will require repeated dilatation, if not a fistula. I have found that you ask the patient to swallow a lot of air. You do endoscopy, you don't find any opening at all. You do barium, nothing goes in, it all goes into the respiratory tract. But you ask them to swallow air and do a contrast CT, you find the esophageal lumen. And you see here, this is the trachea and this is the esophagus, which is not seen on oral contrast. This length of esophagus is partially strictured, which disconnects it from there, but the lumen here is sufficient to do an anastomosis if you can establish continuity between this and this by having a proper tube. Functionally, it is far, far better, and over the years, we have done a lot of these reconstructions of the cervical esophagus, and we are very happy with the results, and more important than us, the patients are very happy with the results. Teaching them how to swallow is much better. Now you have two types of pharyngoesophageal strictures. You have one like this, a small stricture there, and relatively normal esophagus, very easy to treat. You just dilate it once or twice or a few more times, and you will establish continuity. And then my friend Dr. Tushar Chatterjee of ILBS used to ask them, teach them how to dilate themselves using a Foley catheter. And after doing it themselves, after a few times, they are much better. But this is a bad one. You have a pharyngoesophageal stricture, you have a right there, the arrows, and then you have a stricture in the mid-esophagus, and then you have one at the lower end, or this one, where there's a long stricture below and saculations. Now, whenever you have saculations, it's a very, very difficult situation to dilate because the risk of perforation is quite high. And if you have a segment of esophagus which is so long, it's nearly impossible to maintain the lumen by dilatation alone. They will always come back for repeat dilatation. And like dilatation will be a lifelong problem. They'll never stabilize, and they always do much better with a surgical conduit. You may wonder what will happen if you do a neck anastomosis, so much of esophagus remains. It becomes non-functional. Nothing happens. After some time, you see, do a barium swallow, it goes there. It does not fill this segment also. And over a period of time, this segment becomes smaller and smaller. Now, how to maintain the cervical esophagus or keep it accessible in order to be able to reach it when we need it? I have done it, and my residents have been, over the years, have seen us do it. After doing the dilatation, we leave an indwelling tube, a 20 or 18 nasogastric tube, for about 20 centimeters. We don't pass it into the stomach. We don't pass it into the thoracic esophagus. We leave it there. And that provides a passage for access to the cervical esophagus later on if you need access to cut back and enlarge the opening into the pharynx. Or it provides access for doing a conduit and extending it onto the pharynx, or it provides access for dilatation. We always do a feeding jejunostomy. We are very, very lazy to do an early shunt, and I never recommend early conduit. And we like to wait as long as I have a feeding jejunostomy and they take good quality jejunostomy feeds. The problem is our patients will go back to their villages and take dilute milk. And if they don't have money, the milk will become even more dilute. And that is one of the reasons why they don't thrive. And they come back after having lost weight. But if you counsel them and see that they get good quality jejunostomy feeds, waiting for 6 months is not harmful at all. If you have a non-salvageable larynx, the larynx is totally blocked, the epiglottis is shifted backwards, fused to the arytenoids, there is no chance that the larynx can ever be reconstructed. You have a permanent tracheostomy. There are two problems with dilatation of high strictures, and which we have learned by experience. When you have a high stricture like this, and you want to use a Savary-Gilead dilator, as you see here, you pass the guide wire, it curls. There is not enough length for the guide wire to go through and slip the Savary-Gilead over that. So you cannot use the Savary-Gilead. And you cannot use a balloon, because we have tried to use balloons also. When you inflate the balloon, the proximal end of the balloon will close off the larynx, and the fellow will struggle and he will not be able to breathe. And this is an endoscopic photograph I have taken. You see the endoscope there, you pass a balloon, what has happened? It has inflated and is touching the epiglottis, completely closing off the larynx. So it's an extraordinarily difficult place either to dilate using Savary-Gilead or with balloons, inflatable balloons. So what I do is through the right side of the neck, because we want to keep the left side virgin for doing a future conduit. I do an esophagostomy, leave a nasogastric tube like this to keep it patent. And every time we'll divide the nasogastric tube here, bring this end through the mouth, pass the guide wire, it will come out through here. Then we'll do the Savary-Gilead dilation through the mouth And once we establish a satisfactory lumen, we'll repass the nasogastric tube till the next dilatation. And we'll go on doing this till the lumen stabilizes and you have access to the cervical esophagus. And when we are sure that the lumen is stable, that is the time when through the left neck we'll go and do an esophago gastric conduit using the colon. I've also done a lot of biocutaneous flap inlay. Now, this technique is not difficult to learn. I've learned it because I worked in JIPMER, and my unit chief when I joined JIPMER was a man called Professor Satyaprakash, who was very interested in biocutaneous flap. So I learned this technique from him. The muscle is just lying close to it. You slit open the stricture between the cervical esophagus and the oropharynx, and you resurface it by using the skin on the sternomastoid flap and suturing it inside out so that the skin now faces the lumen. And you have created half the esophagus more than what existed before, and therefore you have made it wider for a conduit. We've done a lot of these patients, and I'll show you some diagrams. This is how it looks. This patient had a fistula for some time, then it closed. Or we can use a pectoralis major myocutaneous flap. We take this flap from here and then we tunnel it under the skin and then we put it inside out in the pharynx with the skin facing inside and the muscle outside and use that to dilate the esophagus. And we have done a lot of this also. And in women, we can do it by tunneling. This patient has a keloid tendency. We have taken the skin from here, primarily closed. We have done an incision and tunneled it under the skin and then tunneled it again here and used it for producing the neoesophagus in the neck. Now this is before sternomastoid inlay and this is after sternomastoid inlay. You can see how much more lumen it creates so that you have now an adequate esophagus for doing a conduit from the other side. And this is a patient who had a tight stricture there, would not stabilize with dilatation. And we did a pectoralis major flap because the sternomastoid blood supply was not good. So we used the pectoralis major and you see this, the width of the lumen there compared to the preoperative lumen. Now we come to the last part of my talk about the issues with conduits. Dr. Chandramohan will talk about the conduit necrosis after me, so I'll leave that part to him. And I'll talk about some other issues about conduit. The timing of bypass is very important. If you rush to do it merely because the patient wants to swallow, you will get a cervical stenosis almost invariably because the fibrosis will be progressing. And you'll require one dilatation, two dilatations, sometimes more dilatations. And then they'll come back again unhappy and say, I cannot swallow solids. Stomach as a conduit is good provided there is no gastric involvement and somebody has not thoughtlessly done a gastrostomy for maintaining the feeding. We always advise that, remember, stomach is a potential conduit. If you want to do a feeding ostomy, do a jejunostomy, do not use the stomach. But a lot of patients have gastrostomy and then come. The stomach has become defunctioned over a period of time. It becomes very thick and it's fixed to the anti-abdominal wall. And then what was possible as a conduit before becomes less possible later. Colon as a conduit has been widely used largely because it gives you a good length. Jejunum as a conduit has not been used that widely because it is confined, the length that you can use is restricted because of its pattern of vascularity. And free jejunal grafts are used only for short segments, particularly in the neck. One thing I would like to tell all the surgeons in training, these patients with corrosives have compromised nutrition. They have a contracted extracellular space. In spite of your best efforts to prepare them, the extracellular space is still contracted. So when you give them anesthesia for doing a bypass, when you give these drugs, anesthetic drugs, all of them produce vasodilatation and you'll find fall in blood pressure. in the initial part of the operation. Now, the practice of many anesthetists in this situation is to start a vasopressor, particularly in noradrenaline, as a temporary measure to bring the blood pressure up instead of doing volume replacement. And what happens is, of all the circulation in the body, the one which is most sensitive to vasopressors is this splanchnic circulation. And in this splanchnic circulation, you get severe arteriolar constriction and also venoconstriction, which does not happen elsewhere. So when you have a mobilized conduit on a single vessel and they give these vasopressors, the blood vessel, single blood vessel goes into spasm. And what was looking like an adequate conduit after some time looks a little dusky. And if you don't realize, that compromises. And if it is venous compromise, it's even worse, because on the table it may look good, but slowly it will necrose, and over a period of 6 or 7 days, you will find that part of the conduit has necrosed, and it is attributable 100% to use of vasopressors. So you have to request your anesthetic colleagues at any cost to avoid vasopressors when you are doing a colonic conduit, because it's very, very important that we do not insult the single vessel by giving a drug which causes severe vasoconstriction. I was talking about timing of the conduit. This patient, we had to do a subcutaneous colonic conduit because she had perforation, and after perforation somebody had dilated again and she had a second perforation, and there was total fibrosis of the mediastinum and there was no space in the anterior mediastinum. So we left it subcutaneously. This patient came back 2 years after this with this appearance, with the colonic conduit hugely dilated. You will think that the cologastric anastomosis has stenosed, and that's what we also thought. So we opened the stomach and we found that cologastric anastomosis was quite all right, but the stomach, which had looked normal 2.5 to 3 years ago, had become stenosed, severely stenosed, the gastric outlet, due to progressive fibrosis. All that was required was to do a Billroth 1 resection, remove that stomach, and then 3 months later, the colon came back to normal size. Why I'm showing this is, always be aware of the possibility that fibrosis can go on much longer than you estimate, much longer than you can imagine. And that is another message I want to leave. Avoid doing early surgery as far as possible. And this is always demanded by patients, and you feel like treating them and sending them home. But you can do a lot of harm by this process. There are different types of conduits which are used, and I'm not going to go into the merits and demerits. Conduit is a matter of preference. Each person has figures to prove that it works better. Their method works better. And if I tell something works better in my hand, it may not work as well in other people's hand. I always use this mid-colon based on the left gastric pedicle. I get the middle colic, right colic, and the ileocolic. Don't remove the cecum. I don't measure the length required. I resect at the terminal ileum about 1 inch from the ileocecal junction. Use this end with the umbilical tape for dragging it into place, so that you can decide the length required after you have placed it in situ. Very often you use a tape and you find the root is not under your control. The mediastinal root may not be as straight as you imagine, or when you pull it in, the vessel will compromise and you have to leave it little loose. And I resect the segment only after I have completed the neck anastomosis and then discard it. I have found it's useful because we have never been short of the colon. And I don't think this is functionally so important that we have to worry about the extra colon that we are losing. But anyway, that is something that we have written about elsewhere and published, and is not for discussion yet. And as I told you before, I close the blind end and I do a side-to-side, wide side-to-side anastomosis. What are the advantages of the side-to-side? You can do a much broader anastomosis than you can do an end to side, even if you do a back cut and make it oblique. Secondly, this is potentially the most ischemic end of the colon, and you avoid putting that in the anastomosis. So even if there's a mild ischemia here due to venous congestion, it will form a fistula, but the fistula will not be here, fistula will be there, and it will gradually heal. And the third reason, which I have done in only two patients, this may undergo stenosis. And then you have to open the neck again, extend that anastomosis into the proximal colon and make it wider. So a side-to-side anastomosis gives you a lot of options when compared to end-to-side. And I have never done an end-to-side anastomosis for that purpose. Now I'm not going to tell you results of our conduit because I said it, each one gives good results in their own hands. But what is published literature, and this is the latest that I could find, and this is a large series, a meta-analysis of nearly 1,200 plus cases. And they classify the results under necrosis rate, leak rate, stricture rate, reoperation rate, and 30-day or operative mortality. What they call both is not very clear from the paper, but I think what they mean is where they retain both the left colic and the middle colic pedicle. And in this, they retain only the right colic, and this, they retain only the left colic. And this is the necrosis rate. Necrosis rate in different series varied from 7 to 50%. And for the middle segment, 0 to 14%. This is relatively small numbers. This was the original antiperistaltic left colon conduit described and therefore fell into disrepute. The leak rates high in all, but leak rates are not by themselves significant. But when they become strictures, then they become significant. Reoperation rates are given here and 30-day mortality is given there. So the literature is open. You can do a right colon if you feel like you can do a left colon, and we do a middle colon, and we can be happy with what gives good results in our own hands. Jejunoplasty is a different kettle of fish. Graft loss is more, leak rate is more, stricture it is more, reoperation rates are more, and mortality also a little more than colon. Now what to do? You have done the procedure, and just before you are about to do anastomose, the conduit looks plus minus, and it will be very depressing when you see that. And you have to make a decision. Should we go ahead anastomose? Should we not do it? My recommendation is, if the ischemia looks significant and the vessels are not pulsating, then nothing lost in abandoning the procedure, excising the colon and leaving the patient for another battle on another day, instead of putting it there to see what happens. Secondly, you may have a choice of route. You can see whether by changing the route, you require less, so that if only a little bit looks ischemic, you can put in a different route. At any cost, you must avoid tension. And two recent procedures have been published. I have never tried supercharging, but we have tried delaying in some patients, and I'll mention about that. Supercharging is where it looks ischemic. You anastomose the cervical end of the feeding vessel to a neighboring artery, and if you still feel that dusky, you also anastomose the vein, probably to the internal jugular vein. So now the colon has two pedicles, one from the neck and one from the abdomen, and therefore it is likely to overcome that marginal loss. And there was a series published from one of my students, Dr. Srikanth from Bangalore, and they have done only 2 patients, and it gave good results in both the patients. A few more have been published since then, but I have no personal experience. It requires the help of microvascular anastomosis and probably the services of a plastic surgeon. Delaying the colonic vasculature is when you find you have to do a laparotomy for treating with the gastric outlet obstruction or at the time of doing a jejunostomy, and you feel by the extent of esophageal involvement that this patient definitely requires a conduit, and you find that the left colic pedicle, which is your main pedicle of interest, is not wide enough, you can tie off or first clamp the middle colic proximal to its bifurcation and see what happens, whether it affects the vascularity of the middle colon or the right colon. It's like plastic surgery when you want to use a long pedicle flap, but you want vessels coming only from one side. You raise it from its bed and then you suture it back so that all other vessels have been cut except the one which you want to supply. And that process is called delaying of the flap. And the same delay can be done here by ligating those vessels which are to be ligated anyway, so that you leave the vessel which you want to become larger and take over the vascularity of the colon. But you have to be very sure, you have to clamp, you have to wait a long time, make sure that the colon does not become ischemic before you do that. We have done that in a few patients, and we have found when we went in for a conduit that the left colic pedicle has become significantly bigger. This is the paper I was telling you from Dr. Reddy and Srikanth from Bangalore. And they mentioned that both artery and vein may require supercharging. Recently in the IASG meeting, we had another paper of somebody presenting a few cases of supercharging in ischemic colonic conduits. So I want you to leave you with those messages which I have learned, and the last 40 years since I started managing these corrosive strictures, we have seen some 700 odd patients of various types. And I find that every patient is a little different and you really cannot have protocols. You have to match the treatment for the individual patient. What works for one patient will not work for another and may not work as well. And therefore, you have to decide on every patient when to operate, what procedure to do, when to do it, and how to follow up. And that's about all that I want to tell you. And thank you all very much for a patient hearing. And we have a few minutes, if Pata allows, for some question and answers. Thank you, Pata. Thank you, Chandrapal, for...
Thanks, sir, for such a wonderful lecture, a master lecture, as always. Actually, we are running short. We are going into Dr. Chandramohan's time. We'll have two quick questions, sir, before...
if you have any...
Chandramohan, you have a comment to make? Yeah.
If you have any chat questions, you can take it if you have time, or they can write to me. I will mail them back.
Yeah. CM, sir.
One suggestion is allow the students to ask questions to sir, and I can curtail my time. He can, with his experience, you allow him to discuss with the students more than we can reduce my time.
Kanchan, you had a question. What is that?
Sir, can I ask?
Yeah, Kala, yes.
Sir, as usual, wonderful talks, and we keep learning from you every day.
Kalai, you have not stopped asking questions for the last 15 years. How long am I going to answer? Ask.
So my question is regarding that endoscopy at 7 to 10 days, because that is something which
very controversial.
So for their benefit, for their benefit, you can just clarify in what group of patients you would do on that time period.
Okay, we would do on everyone endoscopy as recommended within 24 to 40 or 48 to 72 hours. Only purpose of that endoscopy is to ensure that there is no damage or there is minimal damage and the patient can be safely sent home. For everybody else, if they have symptoms of dysphagia or any difficulty, I would repeat the endoscopy after 1 week or sometimes even little later in order to assess the extent of damage and the depth, so that we can counsel them properly and put them into the proper group for management. But as you have seen me do, we always do it without insufflation, and we do it keeping the lumen at view, and there's no attempt at retroflexion. And if you do it slowly and slip it down the esophagus, if they're going to perforate, they're going to perforate anyway, and by then they would have perforated spontaneously. Or you can call them back after some time, wait for natural perforations to happen if necessary, seen by CT and other things, and do it after 2 weeks when the risk of perforation is reduced. But everybody requires a second endoscopy for truly assessing the depth, because the first endoscopy does not give you any information, worthwhile information for classification. Is that all, Pata? Shall we sign off? Chandramohan has to start and I have to listen to him.
No, sir, you finish it, sir. I can cut short my.
So can we ask some doubts?
Yeah, please ask, Kanchan.
Sir, 2 questions, sir. In one of the barium solos of pharyngoesophageal stricture with, one with multiple distal strictures, barium you showed. Similar case we had in the last case presentation also. So if there is a lower esophageal stricture, what will be the management? Do we still anastomose do we do the coloplasty with the cervical segment, or we can do in the do a transhiatal gastric pull-up or a coloplasty also with the remaining esophageal segment?
One message I would like to leave with you, Kanchan, is avoid intrathoracic anastomosis at any cost. It's not worthwhile taking that risk.
Even though it is short segment stricture, sir?
Short segment strictures are very often treatable by dilatation. They seldom require conduits.
If they fail dilatation, sir?
If they fail dilatation, then it is better if you are doing a resection either by thoracoscopy or take out the whole esophagus and bring the conduit to the neck. That is the safest option, and putting it anywhere in the chest is not a safe option.
Okay. And my second question, sir, while evaluating any pharyngeal stricture, a high stricture or a high cervical stricture, on the barium, how do you evaluate how much centimeter of the remaining cervical segment you have? Like, is there any level of the vertebra that you have to correlate with the level of the barium that you have?
You know that normally the pharyngoesophageal junction is at C6 level. Is it not?
Okay. Yes,
so
sir.
You can measure from there.
Okay.
And barium anyway is of no use, because the problem with barium is if there is no opening, it will not go. If the opening is too small, not enough will go, and if enough does not go, then not enough below that to show you the width of the remaining segment. So it's much better estimated with a CT rather than with a barium.
Okay. And one more very basic question, sir. I'm sorry if I'm asking a silly question, but in the barium, if there is only like you said that there will be saculations. So how do you differentiate whether it is a sacculation or is it a normal peristalsis? Which is
there is no peristalsis. You remember, this is a damaged esophagus. This is a badly damaged esophagus. Where is the question of peristalsis? It's so badly damaged, transmural damage, except that it has not perforated. There is no question of peristalsis. If you look at the picture, you will know what it is. There will be small outpoachings of barium all along the esophagus. And I showed you that picture. That's how it will be. And when you pass a guide wire, the guide wire will go into one of those sacculations and perforate.
Okay, sir. And one more question, sir. Last question. For the retrograde dilatations, you told that you will do a right cervical esophagostomy.
Yeah.
And in few papers, they have written that we can do a gastrotomy also. So if we are doing a gastrotomy, do we keep a Foley's catheter or something like that?
See, gastrotomy for doing retrograde dilatation will be required only if the stricture is long. If what your aim is not to dilate the whole esophagus, your aim is to provide access to that residual cervical segment from the mouth. Right?
Okay.
And therefore, opening the abdomen to do a gastrostomy, passing a retrograde guide wire, passing a dilator is not required. All that you require is about 5 to 6 centimeters of esophagus belong the pharyngoesophageal junction.
Okay, okay, sir. So is it obsolete now, the gastrotomy and the retrograde dilatation?
I don't know, I never do it. So I never say anything is off now because others may do it. I never do it.
Sure, sir. Thank you so much, sir.
Thank you. So you have asked questions for 10 people. So I think there's Chandramohan, we can't really hold him forever. So
you can finish, take off my time also. I can present.
No, Chandramohan, that's not fair.
Another day.
So Patta, I think the rest you please send a message. They can mail me. I'll try to answer.